I'm going to talk about artificial intelligence in cardiac MRI, but many of you don't do cardiac MRI, so I want to give a framework of how you might consider this. As Diego said, I'm an academic and a clinician, and recently to get AI to point of care for drug development and for patient care, I founded a company because companies allow you to do things that can change clinical practice. So this is my talk content, setting the scene and then a roadmap and showing the steps one has to go through. And these steps are relevant to everyone. And what I'd like to highlight is that one day you might be a purchaser of AI. I want to give you the sort of frameworks to consider whether it is going to be useful for your care. Right, so cardiology is really very based on medical imaging. It is absolutely at the heart of our clinical care. But there are new therapies coming along at the moment that are really going to shake up what we do. I'm thinking particularly of cardiomyopathy, both diseases like ARVC, DCM, and HOCM, but also the infiltrations such as amyloid and Fabry's, where I think we're going to get new therapies that really work. And they're going to be expensive, and we need to get the diagnosis right. When we do a diagnosis with imaging, we signal two things: the diagnosis, which is a label that we can then act on, and the confidence of that label. So our AI needs to be able to help us reach a diagnosis and communicate uncertainty. Only that way is it actionable. So right the way through this is, can you trust the AI? So we can use AI in a lot of different areas. At one end, it's quite trivial, and it's the things we do in our day-to-day lives. And at the other end, there is a real challenge of black box systems. Even the word AI has become problematic because it's confused with artificial general intelligence and, for example, large language models. I'm going to really focus on machine vision and what this can do in our healthcare. The reason you've invited me now and the reason this is happening is because of a number of insights, and it's worth remembering what these are. The first is that people have thought about it, and that copying the human brain and developing this architecture called convolutional neural nets has really made a big difference. So that's a sort of intuition. Then over time with Moore's law, we've had compute. So this laptop I'm talking on now has 2,700 cores. It's incredibly powerful, and this power is available to everyone because they're getting cheaper and because of cloud services. The other thing is that the programming that many of us did when we were at school has got much, much simpler. So new languages have been created that are more accessible, and in a few lines you can code an AI network. And you can see that these languages have evolved, going from academic institutions to industry and now to social media, really leading the way with the development of these languages. Anybody can learn stuff. Access to information is now democratized, e.g. on YouTube. And to train these, you need a lot of data, and that data is now available. We have big biobanks. We have assembled multi-institutional data sets, and we've created the test data sets. We are in cardiology a bit behind neurology, for example, but we're getting there. A final thing is that there have been competitions to get things going, and those have been very effective. You take a photo of this slide. These are some links to AI resources that I have listened to extensively for hours online. And if you're a young starting person, please learn Python, because there are so many people who need to be able to embed the AI into clinical care, and the key language for that is Python. So how are we going to change care? Because that is surely the aim of what we're doing. This is my most important slide, and many of the AI tools are in the left-hand side of the screen where a computer scientist has developed them. but we need to go from left to right through different sorts of teams, different sorts of data, different stages and different metrics until we are adopted in clinical care and then changing that clinical care, using it for new uses and to redefine care pathways and disease definitions. I'll show you a couple of disease definition changes that have come out in the last few weeks from my group. So where did it start? So with cardiac MRI, and it's similar to other areas, it started with a competition in 2015. This is an international group that make competitions, and that competition, the heart, and it was won by two people who know nothing about the heart. They don't even know what it is at all, and yet they were able to win this competition. And the comparison was with how a radiologist would draw the heart. Not my preferred standard in any way. I want to be better than humans. And being able to segment the heart is a mundane task, but it's time consuming, and it's the first layer and the building blocks on which we base clinical care. Even when you're in the clinic, somebody has measured the ejection fraction. And drawing these circles has intra and inter-observer variability and inter-study variability. And that variability is noise, and that noise cascades uncertainty to the clinic. You may be confident about this scan, but if I showed you two scans and asked you whether the patient has got better or worse, you may become more uncertain. MRI is easier than echo, by the way, not because of the image quality, and this is standard image quality, but because all the scans are all the images are part of one scan system, and they're all orientated in space. Whereas when you do an echo, each view is like a new scan, if you like. So once you've got proof of principle, you need to generalize that, and you create an architecture. And this is where the computer scientists do this. And this is actually my cardiologists who are also computer scientists who've done this. This is a convolutional neural net in the short axis, and then with pose analysis to capture longitudinal function as well. These are UNet architectures, but you have to train it. And so we have an architecture, and we take a lot of data from places that we trust, and we take lots of diseases, thick hearts and thin hearts, 1 million images, 3 million images, and we annotate that images. So we draw it as a human, and we feed that data in. But we're not just trying to copy a human. I believe we should try and exceed human performance. And if you're going to do that, the output needs to be better than the input. And we found a trick for doing that using feedback. So we used to look at the network and ask whether a human would draw the sort of contours it was creating. And if they didn't, we found we could go back and refine the contours and improve the training and then improve the output. So how do we test a tool? It's not about whether the contours look good, although that is important for acceptability. You want to know its performance, and the best performance test is with precision. Test, retest, repeatability. And this is a published version. We now are better than this, where the variation for measuring the ejection fraction has gone from 6 to 4%, 6 to 4.2%. Now, for the smallest detectable difference, that difference squares. So if you want to, say, do a cardio-oncology cardiotoxicity diagnosis, having 6% noise is a real problem, and reducing it even a little bit makes a big difference. In fact, this would improve by 40% the power of a trial or the size of the smallest detectable difference. And what about prognostication? So prognosis and predicting your patient's outcomes is important, but more important is linking that to therapy and changing the outcomes. But it's still a useful metric. So if here is 1,500 patients where 250 of them hit an endpoint, and the AI has a higher performance in every single metric except one, the ejection fraction. So overall, the machine learning has got a higher chi-squared. Let's look at this ejection fraction because it's interesting. We've shown that the EF is better by AI using this metric, and yet humans perform better at predicting outcome. And what we find is these are 1,500 EFs measured by machine and by human. And what we see is that humans distort what they measure around the normal cut point and around the 35–40% cut point. And that's because what humans are doing is they're not measuring the ejection fraction. Your echocardiographers and cardiac imaging physicians are trying to influence the care of the patient. And if there are big pleural effusions, we've seen that people put the ejection fraction down. If it's obviously normal, but they're a bit athletic, they'll put it up so that they're in the normal range. Humans do not just measure. The AI is showing us that what we're trying to do is do the best for a patient, get through a clinical list, optimize the care that cascades from these measurements. An important insight. Now, what about measurement ourselves? Well, actually, it turns out that for things like wall thickness, we're even worse. These are 11 international experts trying to measure the wall thickness on this Hokum heart. And these are people who write the guidelines. And they cannot agree with each other to within a centimetre if you look at their results. And they also don't agree with themselves. If you give them the 2 scans on the same patient twice, they measure differently, up to 5 millimeters differently if you give them 2 scans. The AI is much more consistent. In fact, the AI, these are the variations of experts, and some experts, like this expert, is twice as good as this expert. But neither expert knew if they were good or bad. And yet there's a factor of 2 performance metrics across these experts. I'm number 6. Each individual expert in this study knows which one they are, but they don't know anyone else. The AI beat everyone. So for a simple task that takes time, AI machine vision can really help. This is published in Lancet Digital Health. Now, what does that mean? Well, the other thing about AI is we can start to define normal better. And here is us defining what normal wall thickness is in 4,000 healthy volunteers. And you can see that the normal is thicker at the base and gets thinner towards the apex. We know that, but we actually use the same definition of hypertrophy at the base or apex, and currently we use 15 millimeters. This is the upper limit of normal, and you can see that in some patients, 16 millimeters could be abnormal. Let's look at that a bit further in a minute. What we're seeing here is ways of displaying information. So we're now displaying wall thickness, and you can very quickly see spiral hypertrophy. This amyloid here looks very much like TTR rather than AL. You get your eye into these very quickly. And so if I show you these 2 patients, well, this is spiral asymmetric septal hypertrophy with apical concentric hypertrophy, and this one is more severe, and there's an apical aneurysm. So new ways of using AI to display information is very helpful. So how could you made a tool, but it's still a toy unless you use it. So how would you deploy it? Well, that's difficult. You've only got a few points in the healthcare system. We like to put it onto the scanners. Other people have it in the packs, or you could have vendor neutral post-processing software. But you have to get into the system and get this into hospitals. That's why we spun out a company, for example. This is our software running on our scanner. So we now do 1,500 patients a month. I don't draw circles anymore unless I have to draw the right ventricle. And that will be ending within a month because we've got an RV model that's going through the quality processes. You need to do this in the way people want. So these are contours. Let me just stop them on a phrase. These are contours done by the machine. And you'll see that on the left-hand side, there are smooth contours, and on the right-hand side, anatomically correct trabeculated contours. We use both, but each of them has their own specific reference range appropriate for the modality. You can see that this is a very asymmetric heart, and that it's really making decisions as to where to draw. You may agree or disagree, or you may draw slightly differently, but these are certainly plausible in their contouring. If anybody shows you AI, ask for the errors. So these are errors, and the interesting thing about the errors is that they're quite rare, 1 in 28 cases with the network we trained, at least significant errors. Any form of errors is more common, but they're always an explanation. So here are errors because of a metal mitral valve. Here is an apparent error because of Barlow's and a marked billowing of the mitral valve. Actually, I would argue that this emergent behavior is actually correct for the cardiac function, because that valve billows so much that there's effectively no long axis function. And from a cardiac output point of view, the AI is doing and drawing and measuring something that a human wouldn't, but that the AI is really correct from an EF and stroke volume perspective. And you see here that the trabeculated model struggles more with artifact than the smooth model. That all of these have an explanation, and we can refine these over time. So that's nice. We probably made healthcare a little bit faster and a little bit more precise. What about accuracy and disease definitions? Well, the first one we did was published last week in JACC Imaging, and that was this 15 millimeters. So the normal apex tapers, you can see that here. We all know that. 15 millimeters is difficult to get to at the apex compared with the base. It takes more hypertrophy. So about 10 years ago, we created this concept of relative apical HOCM, where you had all the features, the ECG changes, loss of apical tapering and hypertrophy, but not to 15 millimeters at the apex. You also see the cavity obliteration and the microaneurysm and left atrial dilatation. So we had this workaround called relative apical HOCM, but we've now measured the apex, defined what normal is, and it turns out that normal is not about your age or sex, but it's just about your body size, and 5.6 millimeters per meter squared is the cut point for normal. And in the context of high pretest probability, i.e. that lateral T-wave inversion, this is a new proposed definition for apical HOCM. Published last Friday, you can have a look. Apical HOCM is not controversial. What about HOCM itself and 15 millimeters? Well, 15 millimeters was defined in 1951 on 15 patients, and the paper didn't even say whether they were male or female, what ethnicity they were, and what age they were. And you can immediately see that 15 millimeters will be easier to get to if you're a large male, maybe older, than if you're a small female, younger, maybe Asian person, for example. So there's a bias potential in this. So we're starting to look at this. We can see that most clinics around the world, and I suspect yours are no different, have a 2-to-1 male to female skew in them, and yet mostly HOCM is autosomal dominant. So maybe that's about sex hormones, but maybe it's about ascertainment. So we created a normal range, and this is with epidemiologists, and we used biobanks in the UK, in Framingham, and with Dallas Heart Study. Soon we're going to add ethnicity and comorbidities. My friend Katia is coordinating the scanning of Latin American patients, and 130 healthy volunteers have been scanned in Latin America. Laura Dragonetti is trying to do some Argentinian patients as well, so subjects, so that we can define normal for a continent. These are pseudo patients showing that 15 millimeters is what we use currently, but is too high for a small female and too low for a larger, mainly male patient. Does that make a difference? This is looking at UK Biobank, 43,000 subjects, quite a lot of them with hypertension. And what you see is that these are the wall thicknesses of males, the larger ones, and females. And there's about a 2 or 3 millimeter difference between the average male or the median male and the median female. And when you do 15 millimeters, 8 times more males than females have greater than 15 millimeters. There is something wrong there. And if you personalize that, it comes to a much more biologically interesting 1.3 to 1. So this is work we're doing in a consortium. And we're finding that we're seeing in the HOCM clinics, and we put together 2,500 patients that we can look at, that there seems to be that many of the males and older males who are gene negative, very often hypertensive, do not seem to get to their personalized threshold. And yet there are some missing women in the clinics. And where the women are there, their Z scores are actually higher than the men, even though their wall thickness is lower. So it looks like we're diagnosing female patients late. Now, in time, imaging with the AI approaches needs to be complemented with other approaches and new biomarkers. We're using AI to do that. We're also using AI as part of the analysis chain, and that's bringing new tests like this perfusion, which is fully quantitative. Here is the flow at stress in mils per gram per minute in a HOCM patient, and you see these profound perfusion defects. This isn't just fibrosis. This is really serious ischemia that may be one of the positive feedback loops in the development of hypertrophy. We are seeing those in every HOCM patient with apical HOCM, whereas we see it in no healthy volunteers. Clearly, there are other diseases that can cause apical ischemia, like LAD disease, but every patient with apical HOCM seems to have ischemia at the apex. We're also seeing, and the AI is helping us here, perfusion defects before hypertrophy, which is probably about the myocyte capillary curve, myocyte capillary pairing, and this may end up being a key part of early diagnosis and disease tracking. So that's AI to try and redefine diseases. What about care pathways? Well, it's early days. My preferred scenario is to start addressing is cardiotoxicity in cardio-oncology. So this is one of our patients who has breast cancer with METs, and she's Herceptin she's HER2 positive, so she's on Herceptin. So we monitor her, and these are her actual echoes and then CMRs over 10 years. So she has a lot of scans. And what you see is that when her EF dropped, no one believed it, no one did anything. When it was still down, we stopped the chemo. And when it recovered, no one did anything. And when it was definitely recovered with a second scan, we restarted the chemo. So in this period, uncertainty about that EF of 46 meant that she remained exposed to a cardiotoxic drug. And in this period, when her heart has recovered, her cancer remained capable of mitosis because it didn't have the chemotherapy drug, if you like. And these two episodes the same. So this is what humans do when they don't trust the imaging. We repeat the testing, and that's baked into cardio-oncology. If we can get more precise, we will be able to do less imaging and actually vary the time. I haven't drawn this in, but we can vary the time of the imaging according to the confidence that there's been no deterioration. And in time, I think we'll need biomarkers as well and dynamically change follow-up. And that will be a great reduction in the pressure on our systems if we can get smarter about measurement by using AI. There are lots of problems with AI. I can't go into them all now, but you can see some of them here. There's a life cycle of AI in the clinic, and how we make it trusted and delivered is uncertain at the moment. There's lots to learn. But I thought I'd just stop there and say that I think AI is transforming society, but healthcare is really lagging. Medical imaging is the best domain there could be because we know that machine vision, computer vision is really good. It's a huge opportunity, and it will be led by people like yourselves. But the challenge is quite complex because we've got to get a lot of people talking to each other and collaborating to deliver it. So I've given you a sort of framework for how to think about things. I don't just want to make our care a bit faster. I want to change disease definitions, and I'm starting and I'm showing you how that might happen with HOCM. And if you want to, I gave you a few hints as to how to learn more.